Good afternoon. I'd like to welcome everybody. My name is Robin Morgan, and it's a great privilege to serve as the provost of the University of Delaware. About 3 weeks ago, maybe 4 weeks ago, I started pulling this slide up every day when I came into the office, and it's the Johns Hopkins University website that helps one to track the SARS-like coronavirus that we've been hearing about for the last 2 months. I love this because I can look at where all the cases are, the existing cases, and I can count every day to see how many more there are. It's a story that's been evolving over these 2 months. It's really been a story that's been around longer than that. And it continues to evolve, really capturing the attention of the entire world at this point. Karen Rosenberg, who is a professor of anthropology, Tom Powers, who's an associate professor of philosophy and director of the Center for Science, Ethics, and Public Policy, and John Junct, who's a professor of biology and mathematical science, wrote to me 3 weeks ago with the idea that given this new COVID-19 virus, it wasn't called that then, that they thought we should use the experts on campus to talk a bit about this situation. And I immediately thought that was a great idea. We put our heads together and came up with some ideas. We were going to have a little seminar. And it turned into a much bigger thing with much more interest. And but I do want to thank them. They're sitting down here on the front row, and let's give them a round of applause for getting everybody together. So we're going to have 2 panels today to talk about this situation. And the first panel will be talking about what's a coronavirus, what's zoonotic transmission, how do these viruses evolve and emerge, what are the prospects for control, what's the history of this kind of stuff, these zoonotic diseases that emerge and then can really affect large populations of people. And finally, what is epidemiology? What does that mean? How do you follow these kinds of diseases? We'll then break and have a second panel, and this panel will talk specifically about COVID-19. We're going to hear from guests from Christiana Care, who will talk about infection and spread and current treatments. We will also hear from Tim Dowling about steps that are being taken here at the University of Delaware. And finally, we're welcoming Karyl Rattay, who is from the Delaware Health and Social Sciences Office, and she's the Director of Public Health. I especially want to welcome our speakers who have come from off campus, who've taken time out of their schedules today to come and share their expertise with us. And I'm especially proud to be on a campus where we have a lot of thought leaders and experts who can come together and talk to us about a situation such as this one. So with that, I'm going to turn the podium over to our moderator, Dr. Lydia Timmons, who is an assistant professor of communication. She will introduce the panelists today and run the show. Lydia?
Thank you, Provost Morgan. All right, so our first panel, we have Calvin Keeler, a professor in the Department of Animal and Food Sciences, and he'll briefly describe how a virus emerges and spreads and impacts us. Then we'll have Lawrence Duggan, who is a professor in the Department of History, and he's got insight on what we can learn from epidemics in the past and how that informs what we're doing today. And Jennifer Horney is a professor in the Disaster Research Center here at UD. She's the founding director of the program in epidemiology, and she's going to be talking about how we as a society respond to epidemics and to what's going on. So what I'm going to ask is each panelist one at a time to come up and give a little presentation, and then when they finish, I'll open it up to the questions that you guys have in the audience. We have microphones so we can hear what your questions are and the best way that our panelists can answer them. These are not the doctor panelists. The doctor panelists are next. So if it's a specific question about medical, wait for the second panel. But all right, so Professor Keeler, please come on up.
Thank you. So I've been tasked with providing a little virology primer today about what COVID-19 is and its context in the world and its relatives, and how researchers and scientists and medical professors might be attempting to control it and monitor it in the world. So, once I get, how do I get to my first slide? Oh, there it is. So this slide shows COVID-19, and that nice orange blob there in the middle is our friend the coronavirus, or not really our friend. But it's called coronavirus because you see the orange-red spikes all around the virus, and those are proteins, the spike protein that we'll visit a little bit later. And so it looks like it's a crown, so that's why it gets the name coronavirus from that crown. The next slide. So we can get to the next slide. And this actually, Dr. Morgan showed the Johns Hopkins University website. This is from the World Health Organization website, showing the current state of this disease worldwide. And as of today, there were 77 countries that have victims of this disease. There were over 93,000 cases of the disease and almost 3,200 deaths. But what you'll see is we talk about epidemics, or an outbreak of the disease that affects a large proportion of a localized population. And certainly you might consider that China had an epidemic of this disease. But when you talk about, we hear people talk about, is this a pandemic or not? And a pandemic is where a disease is spread through multiple countries and with large numbers of infected individuals. But the WHO hasn't labeled this a pandemic, and it's probably because really for a pandemic you need easily spread between person to person and a sustained human infection. And in this case, although there are 77 countries that have reported the disease, there are several of these countries that reported a case or two several weeks ago and have had no new cases. If you look in the area of China where this disease initiated, and that spike in the left was there 14,000 cases that were announced in one day in China. Now, in the last week, that area of China only has 2 to 3 cases a day. And so there's certainly evidence that, or it hasn't been confirmed yet, that there's easy spread of this virus. And so that's why it hasn't been labeled a pandemic yet, is my interpretation of that. So this shows the current status in the United States. I updated this yesterday, and it's already out of date. There are now 14 states that have the disease. You can add Texas and North Carolina to that. There are 128 cases, and there are now 10 deaths, since a death was just announced from California this afternoon. And I guess the concern in the United States and the people in our part of the world is that up until this weekend, there had only been about 500 tests for this virus, as opposed to thousands in other parts of the world. And so do we have an accurate assessment of how many people have been infected with this virus, this disease? And so we're in the logarithmic phase of that understanding, because by the end of this week, there'll be tens of thousands of tests, and so we'll have a better understanding about its spread and dissemination, but we really don't have the statistics yet to understand how many people have been affected. And we'll talk a little bit about that consequence in a minute. So the next slide actually demonstrates relationships of a couple of these viruses. We've heard about the COVID-19, and there are related coronaviruses, these viruses that look like crowns. And you may have heard of SARS, which originated in 2002, and MERS, which originated in 2012. And these are all related viruses. They're cousins, if you will. And they all eventually, you can trace their origins back to animals. And so that makes them zoonotic diseases of animal origin. And they all originally seem to have originated in some sort of bats. Bats have unique immune systems that make them essentially little repositories for lots of viruses. SARS virus went from bats into civet cats, and then from there went to humans. The MERS virus, Middle Eastern respiratory disease, actually went from bats to dromedary camels, and then to humans. And the COVID-19 virus went from bats through some animal, possibly pangolins in a live animal market in China, and from there into humans. But I also have this slide up here as context to show you the severity of this disease compared to influenza virus. And so the SARS and the MERS statistics there are worldwide, 8,000 cases, 2,400 cases, almost 100,000 cases of COVID-19. But if you look at influenza, those are United States numbers. And in 2017, 2018, which is a very bad year for flu in the United States, there are 61,000 deaths in the United States that can be attributed to flu. So we're talking an order of magnitude difference in the severity of flu as opposed to these coronaviruses to residents of the United States. So, but this is to show that these viruses have originated in animals and they're zoonotic types of infections. So how do we detect these viruses? And so there are, this is a cartoon on the left that shows sort of what this virus looks like, if you sort of do it diagrammatically. And those spikes that were on that first electron micrograph are now these orange cones. And those are called spike proteins. And so that's a protein that's on the surface of the virus. And if you're a virus and you want to attach to a cell, that's that protrusion you're going to use to stick to a cell. Similarly, if you're a human and you're going to mount an immune response to this virus, you're going to look and see what's on the surface. And so that's the protein the human body recognizes to mount an immune response and make antibodies to that virus. So the genome, so that's sort of the functional aspect of that virus that works. And actually what we'd like to do is to be able to detect antibodies to that spike protein. But that hasn't been possible, or they're very early stages of developing those tests. All the tests that have been developed so far detect the genetic material of the virus. This is an RNA virus. And so it's a fairly specialized test, but it doesn't tell you, it tells you whether an individual currently has virus particles in their system, in their saliva, where the swab is taken. But that only doesn't tell you whether perhaps an individual had contracted the disease several weeks ago, had recovered, maybe had a mild form of the disease, a mild cold, and but wouldn't have been detected and registered as having had COVID-19. So that's why when you look at the mortality statistics for COVID-19, people say, well, it's 3% mortality. That's probably an overestimate, because once we developed the test, there are tests that people are now using and developed, and they've been used in Singapore that look for antibodies to this virus. You can do much better epidemiological and analysis of people that have been exposed to the disease, maybe never experienced any symptoms at all, or mild symptoms. And once those individuals are considered and identified, probably the mortality rate will drop significantly from the 3% that is reported now. So I think the 3% value is probably a high value at the current time. So so I would finish that we can talk about vaccines and therapeutics. That's probably a better question to respond to in the question and answer session. I would say right now, when you think about this disease, I would worry more about fake news and hoaxes, right? Washing hands and cleaning surfaces and social distancing are the ways to control and combat this disease, so that you limit that spread. You don't get that serious human-to-human spread. And when you look at the community at large, though, Amazon has removed 1 million sites for products that are either gouging or misleading claims. My reading, it does not work to soak yourself in sesame oil. Eating garlic does not prevent the disease. This is not due to a rollout of 5G. That's kind of the thing. And finally, Corona beer sales have dropped significantly, and Corona beer has nothing to do with this virus as well. So be careful where you get your news from. Thank you.
Yep. You're up.
Thank you. Am I on? Am I on? Okay. Good afternoon. My name is Lawrence Duggan. I am a late medieval, Renaissance, and Reformation historian. My head spends a great deal of time back in the 14th, 15th, and 16th centuries. That's where my head lives. The rest of me has no interest whatsoever, not only living back then, but actually not any earlier in time than the glorious present. And a lot of it has to do with diseases. Back in the 14th century, in the middle third of the 14th century, the plague erupted across the Eurasian landmass. And it went in the direction of China, it went in the direction of Europe. It hit Europe between 1347-48, and that was the first great sweep. And then a second sweep occurred a couple of years later, and very, very quickly the population of at least Europe had been reduced by a third. One often gets the impression from the literature that that was it. It wasn't. The plague came back in Europe at least 7 times before the year 1400, and by then 50% of the population was dead. But that wasn't the end of it. The plague remained in Europe on and off all the way down into the 18th century. It hit London, for example, in 1665, which then was devastated by a great fire on top of it all. So the plague was long out there. It was a major killer, and in fact, it's still out there, and it kills a few dozen people a year in this country. You can raise that question in the question and answer period if you like. In the 16th century, Europeans began to undertake exploration and colonization of the rest of the world, and in the 16th century, they brought Eurasian diseases to the Americas. The native peoples had no immunity whatsoever to any of these diseases, and very quickly, within a couple of decades, Eurasian diseases killed, in many cases, something like 80% of the native populations of the Americas. Most of those diseases seem to have been smallpox and measles. Curiously, the Black Death, or the plague, was not one of them. And once the native populations of the Americas were depopulated, the Europeans began to import slaves from Africa to do all of the dirty work, and so wound up importing, as a result, new varieties of malaria, just in case there weren't already enough in the Caribbean. And apparently there are something like 40 major varieties of malaria. It also seems that in the 16th century, when what we call the first globalization began to occur, it was in this period that influenza, which seems to have gone all the way back to antiquity, now became something of a global disease. In the 18th and 19th centuries, the Industrial Revolution began, cities began teeming with vast populations, and the steam engine made it possible for the development of the steam ship, which made possible for the first time the export of cholera from India to all of Europe and the Americas and the rest of the world, and cholera became a major disease problem everywhere in the world. All of this is going on, and then exactly or slightly over 100 years ago, just at the end of the First World War, In 1918-1919, the great influenza developed. Sometimes it's called the Spanish flu. That's hardly misleading because, in fact, all the evidence seems to indicate that it began in the United States, specifically in an army base in Kansas, and spread from there and then wound up being exported to Europe by the American Expeditionary Forces that went to try to save the Europeans from their latest form of madness, what we call the First World War. That outbreak lasted essentially only about 2 years. The population of the world at the time seems to have been something in the order of 1.9 billion people. Nowadays, it's something in the order, of course, of 7.4 billion people. And out of that 1.9 billion people, it appears that because of the influenza, at least 20 million people died. Many estimates range around 50 million people. And more recently, if you look at the literature, you'll see that there's a tendency toward sensationalizing, and now many people are saying that 100 million people died. Whatever the truth of all of those assertions, we can certainly say that 20 to 50 million people died as a result of this major influenza, which was, in fact, worldwide. There are a few islands in the world that apparently were not affected, and some countries were more seriously affected than others. Iran, for example, seems to have had about 1 million dead, about 10% of its entire population. Fortunately for us, that was the last time, up to the present moment, when this sort of sweeping, killing disease of one sort or another really hit the globe and swept, didn't sweep the slate clean, of course, but did such major damage. And if you look at all of the diseases that we've had in the last 100 years, and you look at the number of people who are estimated to have died, and you compare those figures with the actual population of the country or of the world at the time, there's been nothing like the great influenza of 1918, 1919 in the last 100 years. Ladies and gentlemen, count your blessings. Now, is this a guarantee that this will continue? No, because there are no guarantees in this world. But fortunately, as a result of all of those experiences, what happened was, of course, the development of new kinds of vaccines, and then the development of antibiotics beginning in the 1940s and 1950s. So as a result of vaccination and vaccine and antibiotics, we are in many ways protected. On the other hand, don't take those kinds of things for granted. There was a saying, eternal vigilance is the price of liberty. I would suggest eternal vigilance or eternal cleanliness is the price of health. Always be prudent, wash your hands, do all of that stuff, cancel trips if they don't seem to be necessary. You can do all of that kind of thing. On the other hand, some people are going to be felled, and there doesn't seem in the end all that much that can be done about it. And that is the good news from the world of history on this particular subject. Thank you.
So I'm going to turn it now to the public health side, which maybe brings us towards our second panel, and talk a little bit about some of the terminology and things that those of us who are following this closely are using to stay up to date. So I'm relatively new to UD, but I have spent about 20 years working in public health preparedness and working on outbreaks of emerging diseases all over the world. So I have followed this with great interest from my home here, safe in Delaware. So public health surveillance is something that is happening all the time. We are always collecting, analyzing, and interpreting data about our health. We're regularly conducting that when you go to the doctor, when you have a test. That's reported to the state health department and on to the Centers for Disease Control. When we have clusters or outbreaks, we report those too usually, even if the condition itself is not on our list of reportable conditions. And timely reporting is essential. We need to be able to make decisions based on as complete a data as possible. And so we have something that's relatively new that came out of the anthrax attacks after 9/11, and that was called syndromic surveillance. So this is where we collect real-time indicators. So instead of trying to collect a diagnosis of influenza, we say that someone has influenza-like illness. So we will now be able to look at that data on a daily basis and even to go back at that data for the last 2 months and maybe say, maybe we did have some of these low-grade cases. So I would be assured that this is an ongoing data that is being collected, and this is something that we do on a regular basis, and it's an essential thing that public health does every day. So moving on into a little bit more epidemiology territory, the number of people that one sick person will infect is called the R0. And so for something like measles, which you see there in the lower left-hand side, one person with measles is going to infect 20 people. That's why, going back to our previous slide, it's immediately reportable as a public health condition, immediately. When we look at this new virus, it's sort of in the middle. It kind of looks like SARS. It's maybe one case can infect 2 or 3 cases. So one of the tools that we use when we're looking at an outbreak of a new disease or an old one too is called an epidemic curve. So what you see here with the red is the epidemic curve for just the cases in China. And the caveat that we had to do these slides on Monday, and so these look a little different now. But those are the cases in China. The other curve is the cases in everywhere except China. So I think that everyone can see that there's this pattern of spread that's a normal distribution, relatively speaking, and that the one for the rest of the world looks kind of the same. We just don't know how high it will go, and we don't know how far over it will continue. But it looks pretty similar. It's just delayed a little bit from the China one. So this is something you can Google if you want some real epidemiologic information. So the other thing I think of interest in this particular outbreak is thinking about case fatality. So again, these are just the case fatality rates from China, but if we look at the rates in those who are over 70 and over 80 in particular, we see those kinds of rates that start to frighten us, 8%, 14%. Whereas if we look at the rates in the 20 and 30-year-olds, it really is what we're seeing with seasonal flu, about 2 in 1,000. So when you're thinking about the types of decisions that you need to make, which one of these categories might you be in? The other thing that I wanted to share is that in general, I can't make this go forward. Is there another way to make it go forward? This? There we go. We're really bad at knowing what we should be afraid of. So during the 3 months that followed the 9/11 attacks, 1.4 million people canceled their plans to fly and decided to drive to their destination. That resulted in an excess of 1,000 additional road deaths. So at the same time, we know that roughly 1 in 5 deaths in the entire world is because we have a poor diet. So I'll just leave you with that thought of thinking about how you prioritize things that concern you. And the last thing is, and sort of we have all sort of not made light of, but continued to express that the best thing we can do, or the kinds of protection that we always suggest, washing our hands, social distancing, basic things. So I think that if I were to say I do have some concerns or questions, this is what they would be. We need to increase our capacity to test. In every state health lab, in every regional reference lab, we need the capacity to do that, or else we don't have the data. We need to ensure that all the other countries that are being impacted have the capacity to do this. So the epidemiologic capacity, the personal protective equipment, the laboratory capacity, so that they can provide timely and complete data to WHO and CDC to understand what this looks like globally. And the last thing is we need to provide appropriate science-based data and information to the public. And I will leave it at that. Thanks.
All right, well, thank you, Professors Keeler, Duggan, and Horney, for speaking to us. Now, I would like to have the questions from you guys. What questions do you have for our epidemiologist, our historian, our disaster research person? Any questions yet? All right, well, I have one. Okay, so if this is COVID-19, what happened to COVIDs 1 through 18? Does that mean, was that the Black Plague? I don't know, has that been the Spanish influenza?
That's you, virologist.
Oh, I probably because it was initiated in first identified in December of 2019.
Ah, okay, so it doesn't mean there's been 18 before.
Yeah,
Okay,
so
well, that was
more,
confusing
it's not,
to me.
It's not as
Okay.
drastic.
So,
as
question
that.
down here?
I was curious why polio wasn't listed as one of the great scourges of mankind.
Professor Duggan?
Because there are so many of them that I didn't have a chance, especially since we were told quite explicitly we were going to get 5 to 8 minutes.
And I was glaring
No,
at him.
it was. And in fact, I knew in graduate school several of my fellow graduate students who had polio and were had severe limps as a result. No, that's one of the great conquests. I simply didn't have a chance to mention all of them. I did not mean to in any way ignore polio or diminish it. So.
Okay. Other question? Let's be up here.
Hi. What is it about bats' immune system that specifically makes bats like these great generators of viruses or otherwise diseases?
It's a interesting, really sort of new area of study because people have essentially you screen animals all the time to see what's present in them microbiologically because they are such a source of pathogens for humans. And people identified that bats were these huge reservoirs. So bats are the reservoir ultimately for Ebola virus. And people realize because of their hibernation systems, their immune systems have evolved so that they essentially, pathogens essentially, they also hibernate and they essentially stay and aren't metabolizing and not that active in the bats. And so that's one of the hypotheses of why they maintain pathogens so well.
Kind of
So
spooky.
I think there's also pretty good evidence that there are 400 coronaviruses that would be novel to people that they
Right.
found in bats. So
Right.
we can look forward to many more, I think.
And actually, the viruses we're talking about are beta coronaviruses. So another question is, what about alpha coronaviruses? And there are. So a third of the acute respiratory diseases that humans get in the wintertime are actually coronavirus infections that cause colds. And so this is just essentially another class, another version of those coronaviruses that happens to cause a different form of the disease.
Quick question that probably can't be answered quickly.
Yes.
What are the prospects for a vaccine or antiviral that can be used in humans?
Well, there are lots of potential vaccines. So first of all, everybody and his uncle that developed a potential vaccine for SARS didn't get to produce that or market that once that disease went away. So they're all reintroducing those products, saying, well, maybe they'll work against this virus. They may or may not. There is an interesting antiviral drug that's actually already in clinical trials. They're also trying to get volunteers for it. It's called remdesivir, and it was developed by the NIH in conjunction with a pharmaceutical company, Gilead. And they found that was developed against Ebola virus, which is another RNA virus. But people found in animal studies, it also seems to be effective against SARS and against MERS. And so since it works against animals affected with those viruses, they're already trying clinical studies. They're recruiting people at University of Nebraska to test that. A lot of vaccines are killed vaccines, where you grow up a virus or a pathogen and you essentially kill it, and then give that as a product. Coronaviruses are notoriously bad with those sorts of vaccines, so people will try those, but they may not work. But there's a company in Massachusetts that's so how do you make an animal produce the proteins in them that are foreign to mount an immune response? And there's a company now in Massachusetts that has sort of a new delivery system that they've already produced some product and given to the FDA to try and test. But Dr. Fauci of the NIH is right. Once you have one of these things, it takes a year and a half, because you have to determine first whether it's safe. And so you have to find out that humans can tolerate it. Then you need to determine dosages and administration methods, and so it's a process that you want to have a safe product and not just something that will work but then cause some secondary effects as well. So even though there's something
I would think the secondary
now,
effects would be the problem too, because
right.
it could make it. The medicine makes it worse, gives you something else.
Absolutely. So you have to take all those things into consideration. So even though there are potential now, it's still going to take time for them to be developed.
Yeah, it still takes time. Yeah. We have another question back here.
How are people still being infected with the plague every year in the U.S.?
Prairie dogs, particularly in the Southwest. And a couple of decades ago, farmers in the Southwest, in order to get rid of the problem of prairie dogs, put them in trucks and transported them to California. So if you're out on the West Coast or in the Southwest, stay away from the prairie dogs. The other problem has to do with the development of very large homeless populations in cities along the West Coast, like San Francisco and San Diego. And apparently there are so many rats there, who are the more traditional carriers of the plague, that the plague is out there and it is waiting to erupt. And I happen to know somebody who was one of the great plague historians. His name is Samuel Cohn, C-O-H-N. Anything by Samuel Cohn on any of the plagues is worth reading. Anyway, I wrote to him and I said, a vet whom I had in class said that he has friends who are in these homeless populations out in the West, and they want to know what to do just in case the plague actually erupts among them. And I wrote to Cohn, and he said, carry 2 bottles of tetracycline and basically consume them all at once. You have to move in with antibiotics, heavy-duty antibiotics at the very outset in order to deal with the plague. Antibiotics are the only thing that work with the plague, whether it's bubonic or pneumonic, or there's a third kind called septicemic. So it's out there, it's waiting, and if you don't catch it in time,
nice.
You might be
That's
dead.
a pleasant thought. Thank you, Dr. Duggan. Did you have a question over there?
Is it possible to trace a virus back to somewhere as specific as a certain fishing village and like a certain animal in that fishing village?
Well, I think that actually, if we look at the epidemic curves, only a few of the original cases had exposure to that wet market. So that's when the hypothesis changed to maybe being bats to pangolins, those cute little things that look like armadillos and roll up. But yeah, it's just, that's why they call it shoe leather epidemiology, right? So we find out the sick people and where they've been and do hypothesis generating interviews and try and find out what they have in common. So we're looking for common exposures and basically tracing back. So where did they buy things that they might have been exposed to? And then gathering those materials and testing them. So it's pretty old-fashioned kind of work, but that's why we're called disease detectives. So.
And it's interesting, they've now sequenced 140 different isolates of this virus. And there's a report today from a Chinese group that they've identified 2 different forms of the virus. There's an L form and an S form. And I think it's the L form seems to be a little bit more pathogenic, but that was the form that was initially associated with the outbreak in China, but now it seems to be being outcompeted by an S form, which is a little less invasive, which would be good for everybody. And actually, that form of the virus was actually, if you look at the lineage of it and follow the mutations, it was actually probably the first form of the virus. So these viruses are evolving, and hopefully this is evolving into a slightly less virulent form.
Yeah, let's hope. Well, I want to thank you, again, Professors Keeler, Duggan, and Horney. And if you have more questions, we can save them for the end as well. But I'd like to escort you off stage right. Down here. And I'd like to invite the next panel to the stage without there being a traffic jam of people going down and coming up. So I will not do a song and dance, but you can get the, okay. All right, so as our next panel comes up, I will introduce them. Dr. Stephen Eppes specializes in infectious diseases, especially in children, and he's going to tell us about how coronavirus is treated. And then he'll be followed by Dr. Tim Bowers, who's the Director of Infection Prevention at Christiana Care Health System, and he's going to talk about how we can prevent the spread of infection. Dr. Tim Dowling, the Director of UD Student Health Services, so that's where you go when you need the note, right? But he's going to tell us specifically about what UD is doing about the virus. And then we are joined also, very glad to be joined by Dr. Karyl Rattay, who is the Director of Public Health for the state of Delaware. And she's here to discuss what the state is doing to counteract the spread across not just UD, but across all of Delaware. So, Dr. Eppes, would you like to begin? Thank you.
Well, thank you. I am going to talk a little bit about treatment, but I want to talk about more than that. Advance the slides with this? Yeah, because there's not a lot that we can do for treatment right now, but watch this space. Soon there will be, I think. So Tim and I have kind of tag teamed this. We're both from Christiana. I act as Associate Infection Prevention Officer, which kind of means that I work for Tim. I'll talk about clinical manifestations of COVID-19 and then kind of segue into what he's going to talk about, which I suspect is what's on your minds in the audience, which is what we can do to prevent this from happening to ourselves and to our population. So the clinical features that you see here are from one of the original publications that came out of China. There have now been other publications that will give slightly different figures, but these are close and they're good enough for us to go by. So this is a respiratory virus. It is, you heard about bats, you heard about intermediary species, and they're critically important, of course, to coronavirus pathogenesis. But once they get started in a population, it is respiratory spread because it's a respiratory virus. So therefore, what you see on the slide are that you get respiratory symptoms. So fever is present in the vast majority of people who get this illness that we call COVID-19. Cough and other respiratory symptoms are also extremely common. Myalgia refers to muscle achiness. You've all had that, I suspect, when you get the flu or other minor things. Less commonly, you can see sore throat, sputum production, and so forth. And you know, there probably are other less common features that don't even get reported in the literature. The complications are why we worry about this, and they include acute cardiac injury and acute kidney injury, and probably even more importantly, ARDS, or acute respiratory distress syndrome. I've included an iceberg to the right because what I've just described to you probably is the tip of the iceberg. And you've heard it on your news reports that only about 20% of people get significantly symptomatic and that about 80% get mild disease, and there may even be some who are asymptomatic. We'll learn that, as you just heard, when we have an antibody test available, because we'll probably be finding that people will test positive by antibody who don't recall any significant illness. The death rates you've already heard about. 2.3% is the figure that's commonly thrown around, and I agree with our previous speaker. It's probably going to be less than that as we get better at identifying milder cases or more asymptomatic cases. Just the denominator gets bigger, so the rate gets smaller. I hope you don't mind me throwing some real medical stuff at you. On the left is a photomicrograph of the histopathology of a lung specimen in a patient who had SARS. Now that's a different virus, but it's a coronavirus, and I anticipate that when we get data like this from patients with COVID-19, it will be similar. So you see incredibly intense inflammation. This refers to giant cells, destructive changes, often triggering that event that we call ARDS. And you can see X-rays, plain X-rays in the left panel, and then CT scans as you move to the right, that show what radiologists call a diffuse, bilateral, sometimes ground glass appearance of the lungs. Again, tip of the iceberg. These are the people who are getting really sick. These are the people in hospital. These are people who sometimes may die. There are a couple of special populations that deserve mention, and you've heard a bit about this on the news, or maybe you've wondered about it yourself. Unlike influenza, where pregnant women are a major problem, or excuse me, I should say influenza is a major problem for pregnant women, for a couple of reasons. We learned this in the 2009 H1N1 epidemic of influenza. It's because of the respiratory mechanics. You have a great big abdomen, your diaphragm doesn't go up and down as well, so you can't breathe as well, you can't expel your secretions, and so influenza is really harmful for pregnant women. We have not, so far, learned that it's a big problem with COVID-19, and that's a really good thing to know. In addition, so far, small numbers, early on, we're only 2 months into this, it doesn't look like this is transmitted from the mother across the placenta or during the birth process to the baby. So good news there. Children make up a really small percentage of the total number of victims, if I can say that, of COVID-19. The youngest was reported from Korea, and that was a 45-day-old. And then China has reported that some infants are getting pretty sick. But by and large, children aren't getting very sick from this virus. They may be getting it, and they may play a role in the epidemiology of COVID-19, just as they do in influenza, but they aren't themselves getting that sick, and they're not, to any appreciable extent, dying from the disease. But they may transmit it. And as you've seen in Japan, they've closed schools. People have talked about, will we have school closures in the United States? That is keeping an eye on the fact that children are sometimes central to the epidemiology of certain diseases. So this is from the Centers for Disease Control. It has changed over time, but it basically shows you, by virtue of the clinical features and the epidemiologic risks, who we need to suspect for having the illness that we call COVID-19. And Tim Bowers is going to talk much more about this in just a few minutes. But to be suspected of it, you really have to have fever and respiratory symptoms and some kind of epidemiologic link, which could be travel to or some kind of association with one of the areas of the world where we see a lot of this virus. But much more recently, just at the end of last week, the CDC has said, you know what? We're going to open this definition up a little bit, and if it's somebody who's really sick, like ICU sick, with fever and respiratory symptoms, whether they have a link to any of the previously affected areas of the world or not, or a link to a known case of COVID-19, we're going to say that you can suspect infection in those people too. And when testing, which I'll talk in a moment about, becomes more widely available, we'll be able to identify infection in some of those people. So diagnostic testing, this is really what enables us, and I talk about us as clinicians and as public health folks, to do the blocking and tackling, the nuts and bolts of what we have to do with a new infection, which is testing, screening, isolation, contact tracing, testing and screening the possible contacts, isolating them, and so on and so forth. Unfortunately, we have not had a whole lot of testing available in the United States. CDC has had kits that have been available mostly in Atlanta. They did send out testing kits to all the state health departments, but there were some problems with some of the reagents. Some of the kits didn't work out very well, but I think that's been fixed, and I think most, if not all, state health departments now have testing available to them. As Dr. Rattay, I'm sure will mention, we got it in Delaware on Monday. In addition, the FDA, which is the Food and Drug Administration, has recently issued an EUA, emergency use authorization, so that commercial laboratories and other laboratories who have the capability to create such a test can do so, and as long as they do their quality assurance and submit data to the FDA showing that their test is working properly, they will be able to offer it. So you may have heard that on the news last night, the Vice President said that soon we will have, by the end of the week, we will have 2,500 kits enabling 1.5 million tests to be done. I'm not optimistic that that will happen by Friday, but I think it will be in the not too distant future. Again, a key thing for us to have in our toolkit to fight this new disease. Clinical management. I mentioned that there is not a lot that we can do, unfortunately. You heard about remdesivir, which is an antiviral that has already been tried, and certain conditions, it does have in vitro activity against coronaviruses, MERS and SARS viruses, for example, and in models of animals, it looks like it has activity. So the Chinese have already begun a trial of remdesivir, and we will look forward to the results relatively quickly. The other drug that you may have heard about is called Kaletra. It is also lopinavir, ritonavir. This is an older HIV drug that's been around for the better part of 20 years. It's not used in HIV treatment any longer, but it seems to potentially have some activity against this particular coronavirus. But most people are going to get supportive care. That may be in the intensive care unit. That may be on a ventilator, ECMO, all the things that we can do to keep people alive, hoping that their immune system will enable them to recover from this infection. One thing...
Your partner up here
Yes.
to come up.
Sure.
Move along.
Yeah. We're tag team
Yes,
team
you're
this.
tag teaming.
Avoid
So, switching
corticosteroids. We talked a little bit about vaccines. I think in order to save time, I will wait and see if there are other questions about this. There is one Israeli vaccine product that I'm told may be available as early as 8 to 12 weeks from now, but Dr. Fauci from our NIAID thinks in the United States it's going to be more like a year.
Okay. All right. So let's bring, that was a fun.
Yeah, so this is misinformation. You've heard all about it already, but it's a good...
Both present, yes, great.
Well, how about this? So I don't know how the audience feels. I think there's been a lot of xenophobia generated by this virus, and people have been afraid of Chinese people and afraid of packages in the mail from China and things like that. Don't believe that. Be careful what your information sources are, and don't, by any means, drink bleach.
Thank you. Don't drink bleach is sage advice for any time of year. So thank you very much for the opportunity. I am not a physician. I'm not a doctor. I'm literally the only one wearing a white coat, so I understand why you think that. My name is Tim Bowers. I'm the Director of Infection Prevention. I've been a leader in IP for 10 years, but let's get this moving. So the topic I'm going to talk about specifically is about, number one, Christiana Care, one of the largest healthcare networks around, and then your personal preparation. What's being done to make sure this doesn't, if it hits our doors, what are we going to do to stop it, and then how you can actually keep yourself well during flu season. So really, we are guided by our mission and by our values of love and excellence. Excellence being, we actually track emerging infectious diseases all year round. Every year, even when there's nothing in the news and nothing really, hitting CNN, we are still looking at random viruses that are replicating in other parts of the world. And then the love is really anything we do, any process we put in place, we make sure that we keep our caregivers really first and foremost in our minds. How are we going to keep them safe? Because they're the ones that are doing the work really on the front line. So in this particular disease for COVID-19, we're working hand in glove with the Division of Public Health. They've really been a great partner in helping us, whether it's lab testing or whether it's getting information from the CDC. It's been a wonderful experience between the two of us. Really communicating with our medical staff and our caregivers. So you really need a multimodal approach if you really want to get your message. It's not just I'm going to send an email, because Dr. Eppes, when he's in clinic, isn't reading his emails all the time, and he really needs to know this information. So it is emails, it is videos, it is social media posts. There's really a strategy around making sure these messages that are very important to keep our caregivers safe are reaching them. It's not about just doing something, it's making sure that we're able to say at the end of the day that our caregivers are safe. We're going to, when you come into any of our Christiana Care areas, identify whether or not you've had travel. That was easy last week. Man, it felt so long ago. Last week when it was only an outside the United States issue, so we said, if you've been to these countries on your way in and you have these symptoms, let us know, so that way we can protect our community and protect our caregivers. And then there's constant situational awareness. What's going on today? What's going on in the last 10 minutes? If you haven't hit the refresh button on the CDC definitions, then sometimes you're missing out. So we do that constantly. We make sure that all of that translates into action internally, that translates into keeping our caregivers safe and keeping our community safe. So that's a Christiana Care. For personal prevention, we talked a little bit earlier about life choices. I'm going to call them life choices between airplanes and fast food. That was, I thought, one of my favorite slides so far. We've been working on hand hygiene for 170 years. And you think that's hyperbole until you look. It's Ignaz Semmelweis in 1850 had the Sentinel presentation on why physicians should wash their hands, and we haven't really made much movement. So I'm going to say, wash your hands, knowing that occasionally it's not going to happen. If you think about all the things that you touched today, a handrail, a doorknob, and then you've also touched your face, your eyes, nose, or mouth, it's happened. That is the way that not only coronavirus, but influenza, but other rhinoviruses, other influenza-like illnesses, that's how they take hold, because of those droplets that Dr. Eppes was talking about. Make sure that you're, again, keep your hands away from eyes, nose, and mouth. Cough or sneeze into your elbow or into a tissue. And then, of course, what are you going to do afterwards? Wash your hands. It's easy to tell me. Now let's do it. Let's put that into action. Disinfecting things like doorknobs and high-touch surfaces. Don't wait till you're sick to start doing that. I know we think, I have 2 little kids, and once one of them gets a runny nose, we're wiping down everything. Probably should have done that the day before, if it makes sense. Avoid being near, as best you can, someone who identifies as being sick, or somebody where you're looking at them and it's like, well, they seem feverish. They seem like they're not at their best today. 3 feet's about an arm's length. Just try and stay about that far away. Sometimes, if it is a loved one that you have to care for, then make sure that you're protecting yourself. But otherwise, do yourself to keep that distance. And as a leader, I try to be there for my people. But if I come in when I'm sick, what if 2 or 3 of them catch what I have? That's what I think about when we talk about staying home from work. We've all got that drive to be there for our people, but unfortunately, that drive can sometimes make our people have to make that same decision about coming to work when they're sick. I got to talk about masks. You see pictures of people on subways. I saw today a picture of a mask on a cat. It's a thing. So masks, if the only thing you're doing is putting a mask on, you're not actually preventing anything. That mask is going to get wet, it's going to get saturated, you're going to touch it, you're going to move it, you're going to do a bunch of things that are literally antithesis to what you're supposed to be doing during cold and flu season. If you are caring for somebody that is sick, or if you yourself have a cough, that mask is really going to help you in addition to washing your hands, in addition to wiping things down. But if it's the I'm covered, I've got that mask on for the duration of my day, that's not necessarily going to be very helpful. Unless you work in healthcare or work with an employer that specifically needs you to wear an N95, then a respirator is not going to help you. A respirator is specifically fit around your face. It has a seal. So that way 95% of all the particulates that come through that mask are filtered. And that fit test, that seal is of utmost importance to protecting you. So if you've not been fit tested, or if you're like me, have a little bit of facial hair or any hair around your jawline, it's not going to work. So it's important to make sure that you're wearing what works. In the hospital, we have alternatives to N95s, but if you have a stockpile, I know that a few people are looking for them. And you stole my line about garlic, but I'll say it anyway. Garlic may prevent vampires, but it will not prevent coronavirus. And about 100 other things are listed on the World Health Organization's website around frequently asked questions, including the bleach question, including a number of other things that were very, very interesting to me when I read them. So here's a few, I'll say more than interesting, very helpful websites from the Association for Professionals in Infection Control, the Center for Disease Control and Prevention, and the World Health Organization. And that's it.
All right, Dr. Dowling.
Thank you very much.
Yeah, stay right there.
Good afternoon, everybody. I'm Tim Dowling. I'm the Director of Student Health Services. I'm going to be talking about what the University of Delaware has been doing and is planning to do for the coronavirus. So I want to start with preparation. Preparation starts with institutional support and also memory, development of sound procedures, and good communication and teamwork. UD has the unique position of being an institution that does have institutional memory because we dealt with the 2009 H1N1 pandemic right here on campus. We worked very closely with our State Department of Health as well as the CDC during that time. So we've learned lots of lessons. My department specifically has a lot of staff that were there in 2009 and remind us of that all the time. Since 2009, Student Health has prepared for outbreaks that included Ebola, chikungunya, Zika, measles, mumps, and now COVID-19. Our Student Health Services, we drill annually for medical challenges we may see on campus and what is affectionately called by our department as code henge drills. These drills are very important because it helps us as a team come together and figure out what faults we may have, but also reinforces what we do as a team to make sure that the students and the community stay well. With COVID-19, Student Health Services has been preparing for a case on campus since January 24th. We've been putting together triage and isolation procedures in place, working with our partners with the Delaware Department of Epidemiology. I have their phone numbers, their personal phone numbers on my cell phone, and they have my cell phone number. We've developed strong communication processes. University of Delaware has developed a COVID-19 webpage to inform students, faculty, staff, parents, and the community of the latest developments that may impact the university community. The plans we have in place are the result of teamwork within student health, which includes our custodians, front office, the nurses, the practitioners, to teamwork with our University of Delaware partners, which includes senior administration, the emergency management team, environmental health and safety, residence life and housing, global studies, English Language Institute, facilities, dining services, faculty senate, provost's office, the Office of Risk Management, and the Office of Communication and Marketing. We all come together as a team to talk about what we are going to do as a university. Finally, teamwork with our outside partners, including the Delaware Division of Public Health and Christiana Care, have been vitally important for what we're doing for our community. We have brought back our study abroad students from Italy and asked them to self-monitor at home for 14 days prior to coming back on campus. We are moving forward with plans regarding future travel and return to campus after travel, developing plans for a COVID-19 case on campus, and how, in conjunction with our medical partners, to ensure the safety and well-being of the UD community, the Newark community, and the state of Delaware. Preparedness plans are also include looking at large-scale events on campus, the ability to move classes to an electronic format like Zoom if necessary. University of Delaware has set an emergency operations center up as of today that will respond rapidly to issues that may arise on campus associated with COVID-19 outbreak. The Emergency Operations Center will plan responses to multiple scenarios here on campus. Through teamwork, institutional support, sound procedures, and excellent communication, I anticipate University of Delaware and the state of Delaware will respond quickly and effectively to any COVID-19 cases. Thank you very much.
Good evening. It's such a privilege to get to be here on such a stellar set of two panels and some of my favorite partners ever. And I think that's really, really key to mention in everything we do in public health, but especially a response like this. Our partnerships, our relationships, the work we do with others is absolutely critical to a successful response. I started my job 11 years ago. I actually started it early due to the H1N1 outbreak here on campus. And one thing I learned really early on, like my first day of the job, is the investment that has been made in developing preparedness programs in state government. And so after 9/11 and Hurricane Katrina, it became very clear to the federal government and states that we needed a really solid preparedness program and a really solid, robust way to be able to respond. We needed to invest in plans so that we knew how to respond to all kinds of things, hurricanes, pandemics, etc. And so our preparedness team began to coalesce around this in early January. And we've been meeting on a regular basis since then. We've been on, I'm on at least one, if not three, national calls a day, working with CDC, and we've had many, many calls with our partners along the way. We don't have all the answers. We certainly don't have a crystal ball, but we try everything we can to predict what may be happening and to prepare for the evolving scenario. I mean, currently we don't have any cases here in Delaware. We had 8 individuals that we call persons under investigation, and we worked with partners here on those individuals who might have been infected, who had symptoms and had some type of exposure, and all of those have turned up negative. But that is something that we have the capability of doing. We know how to do it, and we can turn it around pretty quickly. Especially now, because, as was mentioned, our laboratory is able to test for COVID-19. But as you've also heard, we're limited in our testing kits right now. So I will tell you the Vice President's comments yesterday that anybody can just ask their doctor for a prescription and get tested is not the reality right now. We're all working hard. As soon as we get more reagents from the federal government, as soon as more hospitals and commercial labs and others are able to test, we are eager to ramp up our surveillance and better understand, like Dr. Horney was talking about, really understand if it's in the community, when it's in the community, how much, etc. But we're not quite there yet. We have been monitoring individuals who have been traveling, specifically from China, but the guidelines have changed as of yesterday. So all level 2 and level 3 people who have traveled within 14 days from those countries, they're to contact us, and we connect with them. We make sure they know what to do if they develop symptoms. We give them a thermometer and a log so they can keep track. And they're also expected to stay home, not go to school, not go to work during those times. So we have monitored up to 37 individuals. Right now we have 4 individuals that we are monitoring. Community spread is likely. We are expecting to see COVID-19 circulating in our community. We just don't know when. Our efforts now, where they were initially really focused on containing it and making sure, that any potentially infected individual can't, expose other individuals, and with our monitoring, we're going to continue to try to do that. We've really been ramping up for the last few weeks, especially once we saw what was evolving in Italy, to be able to what we call mitigate the impacts of community spread. So, since we don't have pharmaceuticals, we don't have vaccines yet, this means, some of the common sense things that you've heard about that are so important, washing your hands, don't touch your face. That's such an important one that we probably don't emphasize enough. Stay home when you're sick. Those are key. But also, we're really working with the school districts, with schools, on what they need to do to prepare and how they should start thinking about, if a school needs to be closed for a day or a couple of weeks, how can they help support continued learning? Same thing with businesses. We're having lots of calls with many different partners, long-term care facilities. What do they need to be doing and looking for? Residential settings, et cetera. So we're really trying to prepare all of our partners across the state so they know what to expect and that they're communicating with us. Our preparedness team, what we have done, and you might have seen in the news journal already, is that we have elevated ourselves to what we call a SHOC Level 2, State Health Operations Center. So many of us are working in Smyrna, which is where our operations center is now, so we can make sure that we coordinate our efforts as best as possible. We opened a call center today. If you have a pen and you want to write this down, 866-408 1899 is our call center number, but we also have an email, dphcall@delaware.gov. And we're doing a lot of things to ramp up our communication internally, across state government, but with partners and to the public. And I think I'll stop there. I do think it's important to emphasize our work with the hospitals to help them be able to surge their capacity if need be, if we have more infected individuals in the state. But a lot of different components of this, and happy to connect with anybody with any questions.
Thank you.
They seem a little scarce.
I forgot that I had a microphone on. I just like standing by that one. So very good question. So there have been reports around supply chain issues publicized. I know that we're working constantly every day with our distributors to make sure that we have the PPE that we need. So that's the way that I'll answer that one. And the other one is that there are a number of patients that come into the ER every day. Coronavirus is definitely first and foremost on clinicians' minds, and they make sure that they keep themselves safe. So if an individual were to look like we're going down that way, then they would follow the CDC's guidelines that we've taught them. We've drilled them. We've made sure that they understand it. So again, really leading with love. We make sure that we protect our caregivers first, and so we give them the PPE and the training that they need to be safe. So the question was everybody with a fever gets an N95 mask. So there's a number of things that have to happen in order to be a patient under investigation, and we are able to, through our EMR and through partners, to be able to help providers identify that. So very good question. Thank you very much for that.
The N95 mask really shouldn't be used unless you've been fitted for it and know how to use it. So the first line of defense, if somebody comes into your clinic or your office and you're worried about it, is to use a regular, easy to put on surgical mask. Mm-hmm. And we're screening not only at the EDs, but our OB triage and ambulatory sites as well.
Dr. Rattay?
Yeah, and I'll just add one more component to this as well. If an individual, especially somebody who is being monitored or who has been exposed and is at risk, we really ask them to call us first, because we want EMS to be prepared, so we don't want them just contaminating people along the way. We want the ED to be prepared so that they're put in isolation right away. It's really important.
Okay, good point. Another question. Yes.
What is the likelihood the epidemic will abate as we get warmer weather?
The weather question, yes.
Well, I can start. Any of us can respond to that. So if you look at seasonal influenza, it tends to occur in the winter months and gets better in the spring. Other viruses behave in a similar way. SARS, which you heard of, really went away that first summer. MERS, on the other hand, has lasted to some extent throughout multiple summers on the Arabian Peninsula, which is not exactly cold. So it's been hospitable enough for that virus to continue. So the answer is we don't know. Most respiratory coronaviruses, the non-SARS, MERS, COVID-19, tend to have a seasonality of January, February, March. Whether we can expect that with this one is really up in the air at this point.
Okay, question over here.
I was wondering if UD has a plan in place for spring breakers coming back to prepare for a possible outbreak.
So we are working on that. That's part of the meeting that we're having tomorrow. There will be messaging that will be sent out to students and parents regarding spring break travel. We've done this before with Zika, where we messaged out to the students before spring break about high-risk areas, what to do in that case, how to protect yourself. We plan on getting the same message out within the next few days.
Okay, we have down front, next person with the microphone's over here. Oh, you have up there? Okay, sorry. Question up there?
Okay, how long does the virus typically stay on a surface without a host?
How long does it
stay on the surface?
How long does it stay on surfaces?
Oh, I'm sorry. Well, I think the answer to that is you know, most viruses can live for hours, maybe a day or two on surfaces. What I find really intriguing and slightly amusing is watching people fumigating the streets, because I don't think that really, you've seen it on TV, haven't you? Which I really don't think that serves much purpose. But as far as commonly touched surfaces, like a desk, a doorknob, a toilet handle, yeah, sure, it can stay for a while on that, and that's why you want to do your basic, you know, hand washing and everything else, and not touching your face to avoid transmission.
We have some questions down in the front. If we have a microphone down here, or we have, okay, sorry.
How should students who live in dorms feel about the coronavirus, since it's really easy to get sick in communal living?
So currently, I would think in the residence halls, the most important thing is good hand hygiene, making sure that you don't touch your hands or your face with your hands. But right now, as far as coronavirus, one, as you've heard us all say, there's no cases here in Delaware currently, and yeah, we all keep knocking wood here. But when people come back from spring break, it may be issues with people bringing other illnesses. It's flu season right now. I would do everything that you normally do to help protect yourself against the flu.
And really, so you should up your cleanliness game, right? So no sharing drinks, making sure that everything that you're using for utensils are clean and scrubbed, and you know, using somebody else's bedding or whatever it might be. You know, it's those that really close contact is really, in a dorm setting, it's hard to get away from, but definitely something you should be mindful during any flu season, but definitely right now.
Okay, right in the front.
Yeah, thank you, John Morgan, Physics. I've been concerned about this ever since the news broke in late January, and it seems to me that, especially in light of the recommendation to avoid unnecessary travel, especially to areas where you're going to be interacting with a lot of people from all over the country, that it would be a really good idea for the university to make it very easy for students living in dorms to remain here on campus during spring break if that's what they want to do. My understanding is that in the past, the university has either required students living in dorms to move out of the dorms during spring break, or has charged them extra money for the privilege of remaining in the dorms during spring break. And I'd like to really suggest that the university should make it super easy for any student who wants to stay in dorms during spring break, rather than traveling around the country and interacting with dozens of other people, to do so. Thank you.
Okay. Okay, all right. I don't think we have an answer for that, but
Excuse me.
we don't have an answer for that. But
Well, yeah, I mean, that was a statement. I appreciate your statement. And like I said, tomorrow, our emergency management operations team is getting together. That is one of the discussions. Actually, I was in a meeting prior to this that we were talking about travel, specifically about faculty, staff, students, but also specifically about spring break and how students are coming back from spring break. We will be messaging. So that is a wonderful suggestion that I will also bring up tomorrow at the meeting that we're having with that group. Thank you.
all right, question in the
This
back?
question sort of feeds off the dorm question. So in terms of the university cleaning, besides what the kids are expected to do, the students are expected to do, carry around the hand sanitizer or whatever, what is the university doing to ramp up the cleaning of, the desks and the doorknobs and the communal bathrooms and all that?
Great question. So every flu season, I meet with the facilities people to talk about high touch points, making sure that we are cleaning high touch points. I've reinforced that again in a meeting that we had at the beginning of February. And actually Friday, I have a meeting again with supervisors from custodial staff that we will be re-emphasizing that, making sure that we are all on the same page about high touch points and the cleanliness of those areas.
Whoops, did this go off? Some of the dorms apparently don't have soap dispensers per sinks. I have a student here, obviously, so I know this. So if someone could check to make sure there's enough soap in the bathrooms for the kids, that'd be great. My other question is, and I don't know if people have answered this before and I've just missed the answer. We talk about the people coming in from the different countries. What about, okay, now Washington and California and New York, and so what about if people have traveled there, or if people have plans to travel there, what do people advise?
So I can take that. Right now, there's travel advisories for level 2 or 3 for 5 countries. The 4 countries that are at level 3 are China and South Korea and Italy and Iran, and Japan is a level 2. There are no travel advisories right now otherwise within the United States or to other countries. So that could change. But at this point in time, if you've been exposed to somebody who's been ill, then you would be monitored and you should pay attention to your symptoms. But there is not specific guidance not to travel within the U.S. or even to other countries right now. And I think as this evolves more worldwide and throughout the U.S., it will just be interesting to see how those change, because it may be there's community spread almost everywhere.
Right. So also to answer that question, that's one of the reasons why the university has initiated the emergency management operations system, so that we can be more nimble. Obviously, spring break doesn't happen for another few weeks. Things will evolve and change. That's one of the reasons why I didn't have slides, was because the stuff I was talking about had changed up until about 15 minutes before I came here. So it's continuing to evolve and change, and we will be as nimble as possible. My student health staff has been, since I've been there, talking and asking students not only about travel, but contact with people who may have traveled that are ill. So we've always had that as part of our triage with any of the patients coming into us. So we are constantly looking at that. I think with the opening of the emergency management operations system that we have, that we will be able to continuously update and change our plans on a regular basis.
Okay, question over here.
Amy Hagstrom, nursing. One of the things that I'm noticing, and I know that Amazon has a premium now on any hand sanitizer. It costs hundreds of dollars now if you want to buy it. I wish I had stock in it. At any rate, what I've noticed here on campus is we go in and out of classrooms even if you don't touch doorknobs. If you go through Trabant, you're going through a Petri dish. There's no hand sanitizer any place. It's buried around corners. Shouldn't we have that at entrance and exits of every building? Shouldn't we be looking at some sort of universal precautions for students and faculty and staff at this point, rather than worrying about some of the other pieces, making sure that we're doing the prevention before we ever have the disease?
So with the 2009 H1N1, they did actually put out more dispensers for hand sanitizer. That will be something that we'll continue to talk about. Obviously, supply is an issue with that also. So it's great to have dispensers, but if the dispensers don't have the supplies for them, what good are they at that point? But again, like I said, tomorrow we are convening a meeting of our emergency management group. The people that head that group were the people that instituted the hand sanitizer stations throughout the campus previously. So I'm sure that's on their radar. If not, I will be bringing it up tomorrow to discuss that and options that we may have.
Okay, do we have any other questions? Right here, look for it. Oh, upstairs? Yes, upstairs. That's a good question. Are all hand sanitizers created equal?
No. Actually, there was when I do talks specifically on hand hygiene, there was I think it was a Dateline study where they found that some, I'll say off-label hand sanitizers were found to not have the alcohol that was on their label. So the CDC recommends greater than 60% of alcohol in the alcohol-based hand sanitizers. Most of the major brands have that, if not more. So that you're usually safe with the major brands. I understand I'm saying that in a time when you need to get your hands on something, but make sure that it has, that's a double pun, make sure that it has at least 60% alcohol in that sanitizer. But of course, wash your hands with soap and water when you have the option to do that, but if not, then use that sanitizer. Very good question.
Okay.
And hand sanitizer is, to a certain extent, only as good as the way it's applied.
Mm-hmm.
So you do it right and you do the webs, everybody forgets the webs of their fingers, and these two fingers everybody forgets. To do it properly takes about 10 to 15 seconds.
Mm-hmm. All right, good point. In the front here?
Hello, my name is Tim. I'm a Delaware-born native and also a student here in university. How do we prevent the spread of misinformation and also to kind of dismiss more the xenophobia surrounding this virus?
That's good. I kind of cut off Dr. Eppes' last thing there. But that's a really good question. That's the challenge I think we have. So since you had started, Dr. Eppes.
Well, that's fair enough for anybody here. But I mean, so certain social media platforms have already taken steps to reduce the number of sort of questionable posts and sites. I think they have to police themselves better. I mean, that's not just specific to COVID-19. You can think of other examples where social media has to do that. But I think as consumers, people who live in the world and consume information, we just have to be very careful with what we look at. The sites that Tim showed, and I hope you don't mind that I point out the DPH site is excellent. So those are good sources of information for you and to steer your friends to.
So I would also refer you to the University of Delaware's coronavirus website, which includes all the information that we have put out as a university regarding this. And we did spend a lot of time emphasizing that we are to respect each other and not to judge people just based on how they look or appear, as whether they're have an Asian origin or any other origin. I mean, I could have traveled to China before I came to here today, and I could have coronavirus. So, not that I'm saying I did, but what I'm saying is that no one knows who here is sick or not sick just based on how they look. And no one should ever be looking at someone and judging them based on how they look. So I would refer you to the letter that I put out when the university first started messaging about coronavirus, and that last paragraph was very important. I know Dr. Asanis also really emphasize the fact that we as a community are a community, and we need to treat each other as a community. So I think the University of Delaware has worked very hard at that messaging. So I would refer you to that site.
And I know you need to end, but 10 seconds to say you're absolutely right. We all have shared these concerns. We created a poster that says there's no face to coronavirus, and it's available on our website, which is de.gov/coronavirus, and you can download it and
put it up in the,
put it wherever.
All right, well, we have reached 6 o'clock, so I want to thank you panelists, both panels and audience, for coming. We hope you've all gotten the answers to your questions and are feeling more confident about the response to this virus from the state and the university. And now please go wash your hands. Thank you.